a non-thyroidal illness, it is a situation where the person wants to go into the shell. They want that their thyroid function should become slow. They want to conserve whatever energy they have in that regards. So what happens is that with the illness, first thing which will happen is that your inactivation of T4 to reverse T3 increases. So your MDI activity goes up and MDI1 activity goes down. The second important phenomena is the cortisol and the cytokines which are released, which are going to affect the hypothalamic axis. In that perspective, they will also inhibit MDI1, which will cause a low level of T3. So first thing, you've already seen that T3 levels have gone down. Now to compensate that, in the brain, your MDI2 activity goes up. What will this do, Vibha?
So MDI2 will increase the T3 in the brain, and that will decrease TSH in the brain.
So TSH will go down. So T3 will go up, and this T3 in the brain will basically cause suppression of TSH. There are other factors which also suppress TSH. This include dopamine, cortisol, which will cause reduced TSH. Yeah. Then cytokines are also going to impair the TRH. So entire axis is thus suppressed. So you've got low TRH, low TSH, which is characteristic. Now this TSH is also bioinactive. So whatever is being formed, because TRH is low, your bioactivity of TSH will also be. So therefore you will have a low T4 and a low T3. So this is a classical central hypothyroidism like picture. Now, how do you know that this is central hypothyroidism or non-thyroidal illness? Okay. Anything else? What do you expect cortisol level in non-thyroidal illness? So if your cortisol is low, it means that there is a multiple pituitary hormone deficiency. As I said already, that isolated cortisol thyroid deficiency is very uncommon. So if your cortisol is high, it is not a central hypothyroidism. If your cortisol is low, then you have to worry, because as I said, cortisol is inhibiting TSH. But if your cortisol is high, then that will explain that. But if cortisol is low, your TSH should be higher in that perspective. So what happens on recovery is that now your body requires more metabolism. So RT3 production by using MDI3 or DIO3 will go down. The T3 production will go up. So your T3 will go up. And your TSH, which was suppressed by so many factors, dopamine, cortisol, cytokine, TRH deficiency, will now come up. So this is what Sayan talked about. Recovery is more like a primary hypothyroidism picture in that regards. So what is significant? Low TSH during illness is normal. If your TSH is high, is it significant, Sayan? If your TSH is more than 10, it means it's even more. So it is significant. High TSH in recovery is important, but if your TSH is very low in recovery, it means there is something wrong which is going on, and maybe it is actually a central hypothyroidism which is there in that perspective, which will give you a picture of that. Now, what are the effects of illness on thyroid binding?
In illness, the TBG production will be decreased.
So in illness, TBG levels will go down. So what will happen?
So free T4 will increase.
So total T4 will be falsely low. So what T4 you are measuring is actually worse. You are overemphasizing the T4 is falsely low in that setting. You will also have release of non-esterified fatty acids, which will basically then disrupt the binding of FT4 to TBG. So you may have a high FT4 and FT4 becomes unreliable. So I said three conditions where analog FT4 is unreliable is illness, neonatal period, and pregnancy. So again, FT4 is not reliable. So you may have confusion in that settings. So when we talk about assessment, do not do thyroid function in everybody who is admitted in the ICU. Otherwise, you will be giving too many consultations to the endocrine team. So don't do unless there are indications. What are the pointers of thyroid illness in somebody who is in the ICU? No. When would you think that, okay, this is a sick patient? I said, do only if essential. I should do a thyroid function in this person.
In case there's a teacher suggests to
Like, that's what I'm asking. Okay, what else? Stronger point. What should be the heart rate in somebody who's in the ICU? Most will be tachycardia. So if you have bradycardia, you should definitely do a thyroid function test. Temperature should be more raised. If you have hypothermia, you should do. Hyponatremia plus minus you can do, but again, it's unlikely to be a primary cause. It may be associated in that regards. So do thyroid functions only if essentials and do FT4 and TSH. And if there is a confusion, do FT4 using equilibrium dialysis because that will be more reliable. Would NEFA influence the FT4 level via equilibrium dialysis? The effect of fatty acids, will it affect the FT4? No, will it affect or not?
It will increase and it will be.
So even the equilibrium dialysis will be unreliable in somebody who is on heparin or somebody who is having high non-esterified fatty acids. That will be affected because your FT4 is actually low in the blood. So it will cross, and that's why you will have a high level which is there. Now T3 and T4 are not very good. RT3 is a costly one. If you want, you can do that in that regard. So as discussed, we'll talk about these three parameters predominantly and T3. So you expect TSH to be low in illness and assessment is also low. So you will say, okay, this is same. So if it's 0.1, it is 0.1. Significance is that if it is more than 10, if it is more than 10, it means it's primary. And here comes the importance of third generation and fourth generation TSH assays. If it is illness, very, very unlikely that the level will be less than 0.01. It will be 0.05, 0.02. So this is important. If your TSH is less than 0.01, it is more likely to be a central cause rather than an illness. But this is a subtle point. And if it is high, then you have to consider. What about T4? T4 will be low, but you will underestimate or overestimate the deficiency.
We will overestimate the deficiency because.
So you will find that T4 is even lower. So you will overestimate. When is it significant? If it is high. If somebody's T4 is high, then it's definitely abnormal. This is thyrotoxicosis in that regard. What about FT4? FT4 will be low and assessment, as I discussed, may be variable. So significance is not very much, but you will interpret as per the other results. T3 again going to be low, variable, not very, very important. So the most important would ideally be a FT4 using an equilibrium dialysis with a TSH plus minus RT3, which will give you a picture. But we'll try to use FT4 TSH as a criteria to get the right diagnosis in that regards. So don't do testing in everybody, do FT4 and TSH. Now your TSH is less than 0.05. So TSH is on the lower side. Look at FT4. FT4 is high. This is thyrotoxicosis, no confusion here because high is significant. Low is a normal phenomenon. If FT4 is normal, nothing to worry. This is just a follow-up. If your levels are 0.05 to 0.3, then you do a cortisol level. Now, what will cortisol tell you here, Nami?
So cortisol, if it is very high, then it suggests to us thyroid. In case if it is low, then we are looking for.
So if your cortisol is low, this is central cause. If cortisol is high, this is a non-thyroidal illness, nothing to worry. If it's 0.3 to 4.5, it is fine. So you don't worry about that. If it is 4.5 to 10, you repeat after a week. If it's more than 10, you do a FT4. What will FT4 tell you here, Pratik?
Sir, low FT4 will be even more corroborative towards the primary.
So if your FT4 is low, you have to definitely treat. If it's normal and TSH is not very high, if it's more than 100, that's a different thing altogether, but otherwise you should avoid treatment. So just by looking at TSH, you can easily classify them into thyrotoxicosis, non-thyroidal, central, or primary hypothyroidism in that regards. Now, science 6-year-old boy with meningitis, TSH is 0.1, FT4 is low. What will you do? Is it significant?
It is non-thyroid illness mostly. 0.1.
So TSH is 0.1. So you should look at cortisol. So now what was the cortisol? 760. So this is clearly a non-thyroid illness. Nothing to worry. It's a normal thing. So looking at cortisol is very, very important in this setting. Beba, 4-year-old boy with septic shock, TSH is 0.04. FT4 is 22. So this will go more in favor of a, and T3 is low. This is a confusing picture. So FT4 is slightly high. So T3 I have added because if it was a thyrotoxicosis, T3 will also be high. So FT4 is not hugely high. It's just 22. So you can have that much variation. So here we look at T3, which was low. So it's a non-thyroid illness. If T3 was high, then you would have no doubt. Because you expect T3 to be higher or T4 to be higher in thyrotoxicosis. Because of the other factors, you will have conversion. So T3 toxicosis will happen in that setting. 11-year-old boy, Naveen, with dengue fever, TSH is 12, FT4 is 6. It is significant, not significant. So FT4 is low, T3 is also low. So you have to think of hypothyroidism. Now, why 12 we are thinking of primary? Because this 12 is actually higher. This 12 should have been 20, 30 if the child was not sick. So he has primary hypothyroidism. Because of dengue fever, his TSH has falsely come down. And that's why FT4 has gone further down. So it's not primary. This is a primary hypothyroidism, not a central hypothyroidism in that regards. Dr. Pratik, 11-year-old girl with pneumonia, FT3 is low, FT4 is low, TSH is also low. So you think this is significant? So cortisol level, plan, advice treatment, repeat after 3 weeks was normal because cortisol levels were on the higher side. So this is more of a non-thyroid illness. And why has TSH gone up, Cyan, here? So this is again a recovery. So initial phase is central hypothyroidism. The later phase is primary hypothyroidism.